Hello and welcome to another segment of Interviews That Matter. I'm your host Raj Mehta. Friends, in this segment we bring those guests who influence our lives. This includes elected officials, policymakers, heads of major organizations, and other dignitaries. It is my sincere hope that the knowledge brought in by these guests will help our community. Continuing with our CEO series, today we have Kevin Dahill. Kevin Dahill is the CEO of Nassau Suffolk Hospital Council. He also runs Hudson County Association. Mr. Dahill, thank you so much for coming.
Thank you for
We
having
appreciate
me.
your time this morning.
Good to be here.
Welcome to the show.
Thank you.
CEO
Thank you.
series.
Yes.
Let me normally start with your background, right? So I know you are an MBA with Fordham University, and after that, can you just tell us your background? I know you're in healthcare all your life.
Yes, I've been in healthcare all my life. Hospital administration is what I've grown up in. I spent my first 25 years at Columbia Presbyterian Medical Center in Manhattan. I started there as a nighttime admitting clerk, working midnight to 8 in the morning. And when I left 25 years later, I was the general manager of the hospital, of the Milstein Hospital. It was just a blessing that it seemed like every 4 or 5 years a new opportunity presented itself, and it was a great experience. I left there in 1994 to go up to Westchester County and become a CEO of New York United Hospital. I had been recruited by New York Hospital, which was our formidable competitor in Manhattan. And after I was there 3.5 years, New York and Presbyterian merged. So it all came full circle, so to speak.
Wow.
I left there right after 9/11 in 2000, and in 2001 I came out to Long Island to head up the Nassau Suffolk Hospital Council as CEO, and I've been here ever since, 14.5 years. So it's been a lot of years in healthcare, but I love it. I'm really passionate about healthcare policy.
Good. So tell us something about your role as the council CEO, because I know you're CEO of CEOs.
Right. So every hospital has a CEO.
Right.
So I'm not replacing that role. The Nassau Suffolk Hospital Council is the trade association representing the hospitals. So we are their lobbyists, and we also do a lot of media presentations on behalf of the hospitals. We do educational programs for the hospitals, so if they have an issue in common, we bring in expert faculty on that issue for their staff. And we are a contractor with the state for health insurance exchange, the navigator agency for Long Island. So we help citizens apply for health insurance or Medicaid. That's obviously in the interest of the hospitals to get more people covered. So I interact directly with the CEOs on a regular basis and try to help them reach consensus on issues.
Consensus on issues.
Yes.
Is that difficult or easy?
It's difficult, particularly these days, because the environment is very competitive.
Right.
And particularly here on Long Island, where we have a very large prevalent system in the North Shore LIJ system, and then we have other smaller systems.
Right.
So the challenge really is to help the CEOs understand that some of these issues they share in common, and they're not necessarily issues that shouldn't be addressed just because they're competitors. But it is a challenge. But I enjoy it.
You enjoy it.
Yeah.
You're able to convince them.
To this, very often, not always, but very often I think I'm able to.
Now, healthcare environment is changing a lot. For last so many years, the hospitals has been, either going bankrupt or they've been taken over. Tell us something about that. It's really changing a lot, and how does it affect the patient ultimately?
Right. Well, there's a lot of good news in this change that's occurring. You have to take a step back and look at why it's occurring. It's occurring because we're seeing so many advances in medical science and technology
Right.
that that just dictates that we deliver care in a different way. So hospitals, if you go to the dictionary and look up the word hospital, it's going to say something like that place that welcomes the sick and injured. And when you look at many of our hospitals, particularly in a region like Long Island, you find structures that are hotel-like, right? Because the way we delivered care 20, 30 years ago
Right.
was a lot different than we deliver care now. So, you know, if you were coming into the hospital for gallbladder surgery 15, 20 years ago, you came in, you reserved the day you were coming in, you checked in, almost like you were checking into a hotel, and you stayed 4 or 5 days in there. So our hospitals are built around that kind of a delivery system. Well, the fact of the matter is, if you're having gallbladder surgery these days, you don't stay at the hospital. And you don't even necessarily have to go to a hospital. You can go to a freestanding surgical center and have it done the same day, and you're home that night. So a lot of the change is being dictated by ourselves. You know, we've applied the research from the labs and all this new technology, all the fastest new MRIs and CT scans and all this stuff. And so that's why hospitals, to some extent, and I really want to be clear about this, to some extent have become outdated. Certainly the structures have. And so it's catching up with us very quickly now. We're seeing inpatient volume dropping significantly, and we project that over the next 5 years, it's going to drop perhaps as much as 25%. So in any business that you're in, as a CEO, where you're required to be thinking about strategy, right? You've got to see that coming. And so the role we play at the council is to get the CEOs talking about that. And when they come to realize that this change is really occurring, and they think about where they're going to be 5 years from now, they have to work with their boards and their management team to say, we've got to change. We've got to change. And the change comes in a few different ways. Structurally, we've got to change our facilities. And we've got to find a way to do that. Organizationally, we've got to determine whether we can survive on our own or whether we have to become part of a larger entity. So that's what's happening. For the patient, the person who just interacts with the system, you know, as a patient when they get sick, or it's very confusing because, particularly in a region like Long Island, we call the hospitals community hospitals, right? Because the public considers them to be their public assets. It's like their library or their YMCA.
Right.
So when they see a new name go up on the lawn, or they see a building coming down and a different kind of building going up, they question what's going on here, and that's because it's difficult to keep the public informed.
Right.
One of the things we've undertaken in the last couple of years is to reach out to the business community.
Right.
Through organizations like the Long Island Association and ListNet and the HIA, because employers, to the extent that they still offer healthcare insurance to their employees, they are purchasers of healthcare, right?
Right. Right.
And they want to see an efficient system because they're paying for it at the end of the day. So one of the ways that we're trying to inform the public is through the business community, is to try to go out and explain what's going on. And it's remarkable when I do it. I just did it in Westchester County the other day for a group. As you start to explain the business imperatives for the hospitals, some of the CEOs of these businesses, other businesses, can't get over what the hospitals are confronting in terms of their issues. But when you explain it to them, the light goes on. They understand some of the things they see on a regular basis, and And some have some good advice to offer too, because they've been through it in their business or
Right.
their industry. You know.
Right, right,
Um,
right. Mhm, mhm.
So it's, you know, patients are the beneficiaries of advances in the technology and so on. But we also have to point out that that means costs.
Mm.
You know, the research that led to the technology being advanced, that costs money.
Right.
Then the technology itself, to introduce it and get it in place, that costs money. And then there's costs, because now you're going to have to change structures in your
Right.
hospitals and so on. So it's somewhat ironic sometimes, because we all want to see healthcare costs come down
Right.
until we become the patient. Then we want everything to be offered we want everything to be used, everything to be available, and so on. But it's understandable, because people are not as informed as those of us that live it, you know.
As you mentioned that, like infrastructure change and, new equipment purchase and all that, they are very expensive.
Yes.
And they do cost money. And nowadays, many of the hospitals, they are barely in a black, barely, I'm saying, and the laws are such that many times they cannot even collect the money.
Right.
So how do they, where do they get money from to do all this improvement, unless, it's taken over by North Shore LIJ and put in a lot of money in there?
Right. Well, even with North Shore LIJ and these larger systems, there comes a time when there's not going to be enough money
Right.
to address every issue.
Exactly.
So, and so this is somewhat controversial, because in New York State law doesn't allow for-profit health care to be delivered in the hospitals. Does not, no publicly traded companies, no nothing. But yet around us, in all of the states around us, that is going on. In Pennsylvania, Massachusetts, so on. At the state legislature, there has been some bills introduced that haven't gone anywhere yet, but that would allow for some demonstration projects to try to bring in some new capital. You know, it's interesting that if you look at the hospital sector as part of a larger healthcare industry,
Right.
you're absolutely right. The hospital sector struggles at times, particularly the hospitals that don't do a lot of what we call high-end work, tertiary work. They tend to be more medical hospitals taking care of chronic disease and so on. But if you elevate the discussion to the healthcare industry in general in this country,
Right.
there's a ton of money in the healthcare industry in this country. All that research that I talked about, all of the private sector development that goes on. Look at General Electric. They have a whole division that does nothing but healthcare, technology development and so on. And on any weekend, when anybody's watching their favorite sports thing on TV, look at all the advertising that goes on. It's all health. It's all pharmaceutical driven,
Yep.
and so on. So it's interesting to come to find that there are a lot of hedge funds, a lot of people with investment dollars that would love to get into healthcare.
Right.
And so they get into it with particularly new, innovative companies, incubator type, groups that come together. So it begs the question, though, with all of the restructuring that has to go on, is there an opportunity, if you introduce that kind of a investment opportunity in the bring it now back down to the hospital sector, could you find the capital that's needed to do this? I'll be very honest with you, I happen to think the time is right and it has come and that it should happen. It's controversial even within my own membership. It's just ideologically, some of the CEOs still have a problem with getting away from the community benefit part of this. But I have not seen any evidence in these neighboring states where this has been going on that when you introduce for-profit companies and investors, that you lose the community touch. you're going to still have the same change that we've talked about, but it can provide the capital if it's structured properly. So if there's something folks should be watching in the next year or two in New York State, it's that. If some demonstration projects are legislated, I think we're going to see a whole new way of investing in hospitals here.
So you are working on that changing the health policy for the New York State, because New York State is very liberal in terms of providing healthcare, right? And that's why many times the hospitals cannot collect, and also they are depending on insurance companies many times and Medicaid, right?
Well, there's so much going on there that's changing. New York State has a history of being the most generous state in the country in terms of its Medicaid benefits.
Right.
Generous in terms of the numbers of people that we allow in. Here's an interesting statistic. Over 25% of the total population in New York State is enrolled in Medicaid.
Wow. Over 25%?
Of the total population.
Wow.
When you go to the northern reaches of this state, the economic conditions are pretty bad. If we didn't have Wall Street here, paying what they pay in taxes on all those bonuses that they give out and whatnot, I think New York would be in some bad shape economically. We're also very generous in Medicaid in terms of the array of benefits we offer. If you get on Medicaid in New York State, you're entitled to the whole gamut of medical services. Medical, dental, podiatric, everything. Many other states, that's not the case. It's a basic emergency room, hospitalization, but they don't offer all that wide array of benefits. So that's one issue. Now, with the passage of Obamacare at the national level, New York State opened its own insurance exchange 2 years ago. That has allowed new insurers to enter the market because Obamacare is very prescriptive about price points that have to be made available to the public. So what's being offered when you look at some of these new insurance plans are, yes, lower premium plans, but much higher out-of-pocket expense to the patient. We're now just seeing it because now people have come, they've gone to this exchange, they've gotten new coverage, now they have a card. So now they come to the hospital or to the doctor's office only to come to find out that their doctor doesn't participate in that plan.
Wow.
And then they come to the hospital and the hospital tells them, well, we participate in the plan, but you have to pay the first $7,500 up front.
Right. Wow.
And they're shocked. Now, we hear from those that do the enrolling, we told them, but, nobody processes it. They just saw the lower premium. They took that plan, and now they've got a $7,500 deductible to pay. The hospital ends up becoming sort of the bank now, right?
Right.
The hospital has no choice but to collect that from the patient before they can even bill the insurer. So it's just another complicating factor that has happened. So, when any of these new public policy things happen, like Obamacare and the exchange coming on, the good news and the news you hear most often is, well, we enrolled so many new people in plans. Right. But as usual, the devil's in the details. And when, we have to help the patients deal with that, it can be difficult.
But the patient may not have money many times. Like for example, in the law, if that's like everybody goes into emergency room, right? So emergency room, when they come in, you have to treat them. Right.
Emergency room is a federal requirement that you can't even have a conversation with the patient about finances until after you've taken care of them.
Right.
So that's a given, and that's been that way for a number of years. In New York State, we have what's called a charity law. So now, let's take that example of the patient who's got a $7,500 deductible.
Right.
And then says, I don't have that money. I can't pay that.
Right.
The hospital's required to have the patient substantiate that. So you do a financial screening test on on the patient to determine do they not have assets, do they, but then you can get into very difficult issues. Like what assets are you going to go after, you know?
Right.
Is it just income? Is it cash? Is it a home? You know, we've heard horror stories. Not here. It hasn't happened here. In other parts of the country, where people have had bills that way more than $7,500, $20,000, and hospitals have put liens on their homes. And so we just don't want to get to that point. So you have to go back to the enrollment process and say, how did this person qualify for this coverage in a plan that's going to require them? You know, that question should be asked up front, not when they get sick and they take. It should be asked up front.
Right.
You know, do you understand
Right.
that to access the system, you're going to have this money in the bank somewhere?
Right. Right.
And if they don't have it, then they should be on Medicaid. You know, they shouldn't be put on these commercial plans. So those are the kinds of things that have to be worked out. But it's like anything else. Once you mobilize a new business venture, I don't care what it is, you know, snafus occur and things come up, and you have to figure out new ways of dealing with it. And that's what's going on with that.
I know it's you know, like it's very difficult. Like somebody walks in and say 7,500, I don't have it by the time, you know, but I need care now.
Right.
So the hospital has to decide whether, you know, before even they find out whether what assets and all that.
Well, 9 times out of 10, you provide the care. I mean, unless the care is totally elective, you know, if it's plastic surgery, that becomes an issue sometimes. You know, I want, you know, somebody comes in with a laceration of the face, and you stop the bleeding, you stitch up the laceration for sure, so you take care of the immediate problem. Well, now all of a sudden they want reconstructive surgery, so they look like new again, right?
Right.
That to us is an elective procedure. First of all, it doesn't have to be taken care of right away, and then you can explore further whether or not they've got the financial resources.
Right.
But so, you know, I always say to business groups when I talk to them, think about this in your own business. If you had to be available 7 days a week, 24 hours a day, if you had a requirement on you that said a customer could come into your department store and say, you know, I see that lawnmower over there. I need a lawnmower because my grass is growing so high, but I don't have the money today to pay you. So but I have to take the lawnmower. You know, I mean, I know it's an absurd example, but I do it for that purpose. That's essentially what the hospitals are up against. So when business folks, employers say to me, you know, why can't you just run those hospitals like businesses?
Right.
You know, regular businesses.
Right.
You have to explain to them why you can't and why it's very different.
So you were in administration for a long time, in hospital administration, and you know a lot about, obviously you know everything about administration. And I have a lot of friends who are in healthcare industry, and you know, they are basically a caregiver, like a doctors, you know, physicians, that kind of thing, right? And I've seen many times in the major hospitals that there is a disconnect between administration and the caregiver. Do you agree, or second thing is, how do you connect them together? Because I think that's very important.
Very good question, and I have seen it on many occasions. So there's different aspects to this. As usual, it's not as simple as it first looks. So if you look at Long Island and Long Island's hospitals, many of our hospitals are community hospitals, and many of our physicians are what we would call voluntary medical staff. That means that these physicians have concluded their training, they've done their residencies, and they've made a decision for themselves that they want to come into a community, hang up their shingle, and practice medicine.
Right. Okay.
In years gone by, many years ago, they would then apply for what we would call privileges, hospital privileges at the local hospital. And in years gone by, it was considered a privilege to be welcomed on to the medical staff of that local hospital, because the community usually felt an attachment to the hospital, and then by extension would feel an attachment to the physicians on the staff. In addition to that, the physicians could get continuing education through that relationship and so on. What has happened over these past several years is that as the economics have become different and much more strained, the physicians have been as leveraged as the hospitals, particularly by the insurers and the government to a certain extent, but for the physicians, certainly by the insurers. So the physicians have to look, if they want to maintain certain levels of income, they have to look at where they can derive that. And it's not necessarily at the hospital any longer. For some it still is. If they're surgeons, they need an operating room and so on. But for a lot of physicians, they have felt compelled to go and open their own surgical center or their own urgent care center or whatever, because in their mind, and to a large extent, they're right. The only way they can compete and maintain some level of income is to hold on to those services and be more in control of them themselves. Okay. That causes the hospital now to look upon the physicians differently, right? Now they look upon the physicians as competitors. So that begins to explain how the relationship now gets strained. In addition to that, depending on the institution and depending on the physicians you're talking about, it could be further complicated if it's a teaching hospital with faculty. And those physicians now not only want to be involved in patient care, they want to be involved in teaching, and they want to get paid for that. And so there's always a tug and pull between what's the appropriate level of income I should get for teaching residents that the hospital gets and is really, quote, cheap labor. Yet I have to teach them, so I want to be compensated for that. So it's, in my view, and after many years of dealing with this, in my view, it's the external environment that has caused this. With all of the changes in insurance and government payers and regulation and so on, that's what's caused the tension. So a couple of things happen, or possibly can happen. The physicians get so leveraged that they say, look, you want me to continue to provide services at your hospital, you hire me. I'll become your employee, and you deal with all the headaches, you the hospital. And I'll just become. That's one option for the physician. The other is the physicians reorganize themselves into large groups. We haven't seen that as much on Long Island as we have in other regions like the Hudson Valley. But we have one pretty sizable group here on Long Island where the physicians form their own organization, they hire their own administrator, and they try to address their income issues that way and so on. So here on Long Island, as I say, what has been happening for the past few years is that most of the physicians, or many physicians, have opted for the employment model. In some of our larger systems like North Shore LIJ, the Catholic health system, have really actively pursued the employment of physicians. It's a matter, it's going to be a few years before we know whether that employment model works. I'm a little skeptical, to be honest with you, because I become concerned about the physician's productivity. You know, if you're in your own practice, then you're running it, you know, your success will dictate your income level.
Right.
That's a lot different than if you sign on as an employee
Right.
and now it's somebody else's headache.
Right.
And I get concerned about productivity.
You get a paycheck anyway.
Yes, right. So it's kind of too soon to tell whether or not that's going to be an issue, but that's something I would be watching in the next 3 to 5 years.
But can you change that problem with other part of the administration? Like how do you? I mean, everything comes from leadership, right?
Yes, yes, and it requires some vision.
Right.
I think in terms of the physicians, and particularly if we're going to employ them, we've got to find a way to create incentives
Right.
so that everybody's going in the same direction.
Right. Right.
And everybody benefits if we do well. And by doing well, I would say that means we're getting better outcomes for our patients.
Right.
Not, we saw 100 more people, so we made X amount more dollars. It should be not only about how many more people, but how well we did with those patients.
Right.
And how better they are as a result of it. Reward me as a hospital administrator for taking care of patients, for sure, but the outcomes I get for them. And let me create the incentives for the physicians so we get back almost full circle to value. That for all of us, there's value in being together, not competing with each other in separate venues. That's the only way it's going to work, and that's going to require leadership to do that.
Right. Very strong leadership, actually. Right.
Yeah.
I agree. Because of this Obamacare, right? A lot of small practitioners, they are going out of business and they are merging with other larger practice because of Obamacare, as you mentioned before, that it's not easy
Right.
to practice as a small practitioner, and because of the laws, other more like stringent laws are coming on them, right? So it's very difficult.
Yes.
Do you see that?
We do see that. I think that we're hearing percentages now of a decline in private practice physicians
Right.
in smaller groups by 35–40% already.
Wow.
And it's because, on one hand, if the government is going to drive down pricing on these insurance plans and so on, and get more people coverage, if the ramifications of that are that physicians leave or close their practices, then you really haven't accomplished what you wanted to accomplish, because now you're going to have an access problem.
Right.
In Massachusetts, the irony is, if you remember, when Mitt Romney was running for president,
Right.
the Democrats tried to say, what are you complaining about Obamacare for? You did this
Right.
in
over there.
Massachusetts.
Yeah.
Fact of the matter is he did.
Yeah.
He did create
Right.
a coverage for those. And the good news is 96% of the population of Massachusetts has some health coverage. The bad news is you can wait 7–8 months to
Right.
get in to see a doctor,
Wow.
because the same thing occurred up there. And so, you always have to be careful of the unintended consequences of some of these large decisions. And so that clearly is one of them. And for physicians, it's a shame, because by and large, there's always the outliers, but by and large, physicians spent a lot of years in training.
Right.
They invested a lot of time.
Right.
And they came into these communities, set up their practices, and they wanted to do the right thing. And yes, they wanted to make a reasonable level of income, and they should, for what they've invested in all of that.
Right.
And they have been just economically pressured to such a point that it's a shame. Because a lot of them, you talk to a lot of private practice physicians and ask them, what would they advise their kids or their grandchildren? They'd say, don't go into medicine.
Oh, wow.
Which is a shame, when you hear that. And I've heard that multiple times from
Interesting.
physicians.
And now malpractice limits, right? Because I had Senator Camp Hannon here
Yes.
also, and we talked about malpractice limits because some of the states have already passed it.
Yes.
Do you think it is advisable or good for that? Because I think
I think, yes, I think reasonable limits. State of Texas is a good example of one that put them in place
right.
many years ago. And I think, too, I'm a when I mentioned I was at Columbia Presbyterian for 25 years, one of my 4 or 5 year segments, I was a risk manager. So I dealt in malpractice all of the time. And so I've seen it from the inside out. So I have some strong feelings, and I've shared them with Senator Hannan as well. I think the limits are a good idea. But I think that as well, I'm a very big fan of mediation. In that I think that a lot of the malpractice does occur. And when it does, people have a right to be compensated for whatever happened. But what I've seen is the processes, the bureaucracy, the filing of a complaint as a lawsuit could take 6, 7 years before it's resolved. And the costs that go into dealing with that are tremendous. So I think a whole re-engineering of the process along with CAPS. I think CAPS is like solving one small part of the problem. The bigger problem is the entire process. And all of the vested interests really have to come to grips with the fact that it's very inefficient and highly expensive, and too many hands are in the pot of money, quite frankly. The lawyers and the insurance companies and so on. So sometimes these things are very simple and straightforward, and if you had a good mediation system, in under a year you could get a lot of cases resolved one way or another, drastically reduce the cost. So I think re-engineering the whole process and system has got to be part of the deal.
Well, we had a scientist here on our show, and he was doing a research. I mean, they are doing the research on human genes, right? And obviously, that's going to really change how care is given to the patient, or medicine is given to the patient. Tell us something about that. What do you see that happening in the next 5 years, 10 years?
Well, I agree that everything I read and hear from colleagues suggests to me that we're going to see, if we think we've seen advances in technology to this point, the exponential growth in that kind of development is mind-boggling. So I was at a conference not that long ago, maybe 2 years ago, where I heard a presentation by scientists who were talking about the fact that the day is coming, they didn't say exactly when, but the day is coming when we're all going to be walking around with a computer chip in us. And the scenario would be that one day we're driving to work and we'll get a text message telling us we should go see so-and-so because there's been a change in our liver function. That, so, I mean, think about that, just on a, prevention basis. That's incredible. I mean, right? It's great. I think with that comes a lot of costs. Right? Now, this is the risk manager in me, but, what we didn't know in the past, maybe we never posed itself as a major issue, or it did in latter years. And now, if on a regular basis, we're going to know every time there's a change in our liver function or our oxygen output or whatever it is, and we go to address that, there's costs involved in it.
Right.
So I think that when we hear these presentations, I mean, there's nothing more invigorating than going to a presentation like that, be it somebody from MIT or Mass General, or when you hear those presentations, it's very invigorating. I mean, it's exciting, right, for those of us in the business. But when I take a step back as a risk manager and I start thinking about, my heavens, if we're going to know on a real-time basis everything that's wrong with us and the entire population, that's a very expensive proposition.
Yes.
Right? So I think we got to be preparing for that as well as the exciting part of this.
Well, I have to ask you this because, about alternative medicine, right? Obviously, you have your general medication, whatever you get from everywhere, and then you have alternative medication like Ayurveda and homeopathy and a lot of other things happening. And there are proponents of that type of medication, and there are opponents of that kind of. Right. What is your view on that?
My view on it is that you can't not look at any of these things and just dismiss them. So there's a controversy going on right now with Dr. Oz.
I was going to ask you that.
So
Yes.
Mehmet Oz, I
Yeah.
knew Mehmet Oz when he was a resident.
Oh,
Because
wow.
he's a Columbia guy. Columbia.
Right, right.
So I've known Mehmet for years.
Right.
So Mehmet is an excellent cardiac surgeon, exquisite. He's chosen to, expand his career by getting into television and doing what he does and so on. He has always had an open mind to new and innovative things. So I'll give you an example. When I was still there and I was his administrator, he got very intrigued by massage therapy.
Interesting. Okay.
And so he came to us in the administration, and I think he was out of his residency, but he was a young whippersnapper surgeon, right? But he came and he had a hypothesis, and his hypothesis was that if he could bring a massage therapist into the operating room, even though the patient was under anesthesia, and that massage therapist would be providing a massage to the feet and the lower legs and so on, that he thought that the patient's blood pressure and pulse rate would stay suppressed, and that would make for a better surgical procedure and what. Well, to be very honest, again, being the risk manager that I was, but now I was an administrator, I couldn't, I was, initially I said, you gotta be kidding me. We're gonna bring a non-credentialed, the massage therapist is not credentialed. So I kind of hid behind the rules. He then said, well, credential them, right? So I just bring that up to say, so now he's going through all of these challenges with other physicians writing letters saying he's talking about things that don't make any sense and what. He's been doing this for years, but he's maintained an excellent, exquisite career as a cardiothoracic surgeon. Never gets sued, never. I mean, he's really good. So my point is that we all have to have an open mind to these other things and see whether or not they can fit in. He's talking about the fact that you are much better off if you can find ways to take good care of yourself so you never have to come and see me as a heart surgeon.
Right.
He's financially secure enough. He's personally in such a good place personally that's where he's at. That's why he's looking at these other things. So his show and his public things that he does is entirely different than what he does when he's in the operating room. But in the operating room, and by the way, we did that.
Oh, you did? Oh, I was going to ask you that.
We put the massage therapist in. He wrote an academic paper, and now it's done in many places.
Oh, okay.
So he drove that process, right? He was the champion of it. So, I think an open mind, finding ways, what I said at the beginning of the show, if you looked in the dictionary, hospitals are places for the sick and injured.
Right.
Well, if you want to reduce hospital costs and hospital usage, best way to do that is to create a healthier society.
Right.
And so if people can find that through these alternative means, yoga, I don't care what it is, meditation, I don't care what it is. A healthier individual is going to demand less of the healthcare system. So an open mind, I think, is imperative. But unfortunately, we do have some traditionalists.
Right.
Every business has this, who feel like it's the way they have, the way we learned it in Western medicine. This is the only way it can be done. I think people like Mehmet Oz have proven that's not true.
You are also a CEO of Northern Metropolitan Hospital Association, right? So you're
Yes.
dividing your time between the two, and
Yes.
so you're a pretty busy person.
Yeah.
Obviously, you're running
Yes.
around like crazy everywhere.
Yes.
And
yes.
meeting all these people and CEOs and meeting all the lobbyists and legislators and everybody, right?
Right. Right.
What do you do for fun?
I love to play golf.
Okay.
And I've been blessed with a 4-year-old granddaughter.
Congratulations. Very nice.
Thank you. And I am a soft touch with her. And I spend as much time as my son and daughter-in-law will allow us to. My wife and I spend as much time with her as we can. I also maintain a pretty vibrant social network. A lot of those folks being people I've worked with through the years, and make sure we get together regularly and catch up and talk about family and so on. So I think all in all I've managed to maintain a balance that's a good one.
Good. Well, balance is important.
Yes.
Right.
Yes.
Right. Yeah.
Yeah.
Well, thank you so much for your time today.
My pleasure.
Really appreciate it. I mean, it was very informative, and I'm sure there are more occasions that we can have you again here.
Great. Good.
Yep.
Thank you.
Thank you so much for joining us today. If you have any questions, comments, you can email me at rajmitv@gmail.com. That's again rajmitv@gmail.com. You can watch our prior shows on YouTube at youtube.com/Infosys International. That's again youtube.com/Infosys International. Until next time, have a great week. Thanks.
Thanks, Raj. It was great.